Good afternoon, everyone, and thank you for joining in for today's very first College of Osteopathic Medicine's Healthy Conversations with COM event. My name is Mary Hopper, and as chair of the research committee here in the college, I am very honored that our committee chose Dr. Camara Jones for our very first speaker. Dr. Jones really wished for a more interactive session, something where she could engage with her audience and get her message across. But due to security reasons, we had to make a very difficult decision to offer this in a webinar format. We do ask, though, that students will say hello to Dr. Jones in the chat. If you do that, you are automatically entered into a gift basket giveaway. And at the end of session today, there will be a random drawing for a student only, these are students, to win this prize. So go ahead and say good afternoon to Dr. Camara Jones in the chat. At this time, though, I'd like to turn this over to Dr. Charles Henley, Dean of the College of Osteopathic Medicine, to introduce our speaker. Dr. Henley?
Well, thank you, Dr. Hopper. I just want to say it is a great honor to introduce our speaker, Dr. Camara Jones, MD, MPH, PhD. She's our inaugural presenter for our Healthy Conversations with the COM. Dr. Jones was nominated and selected for this event basically for her compelling work and her exceptional ability to deliver a very impactful presentation. A little bit about Dr. Jones. She earned her BA in molecular biology from Wellesley College, her MD from Stanford University, and her MPH and PhD in epidemiology from the Johns Hopkins School of Hygiene and Public Health. She's also completed residency training in general preventive medicine at Johns Hopkins and in family medicine at the residency program in social medicine at Montefiore Medical Center in New York. Currently, Dr. Jones is a family physician. We applaud that. And an epidemiologist, we like that too. And a senior fellow at the Morehouse School of Medicine. Dr. Jones has also had some interesting positions as a medical officer at CDC, past president of the American Public Health Association, which I'm a member of. And she's taught at the Harvard School of Public Health, Morehouse School of Medicine, and the Rollins School of Public Health at Emory. Some of her past honors have been the Wellesley Alumni Achievement Award, which is actually Wellesley's highest alumni honor, which is it's an excellent award. But the one that I'm the most favorable of is the John Snow Award. It's given in recognition of enduring contributions to public health through epidemiologic methods and practice. It's given by the American Public Health Association's epidemiology section and the Royal Society of Public Health. I use John Snow all the time in my presentations to students in epidemiology. But Dr. Jones' life work has been focused on naming, measuring, and addressing the impacts of racism on health and well-being of the nation. And now, perhaps more than ever, we really need to receive this message and engage in this conversation. And so I ask you now to join me in welcoming Dr. Camara Jones.
Thank you so much, Dean Henley and Dr. Hopper. And yes, I really wish that we could be more interactive, but I very much appreciate the constraints that we have right now. I'm going to share my screen. And today, I want to talk about achieving health equity, the case and tools for anti-racism. And even though I won't be able to hear back from you, at least right now, I describe our conversation as having three main sections. The first is going to be to convey anti-racism as a legitimate health intervention. The second is when I will equip you with tools for naming racism. And the third is tools for then going beyond naming racism to moving to action. So don't worry about the details yet. You're going to recap that at the end. But I'm going to start with the definition of health equity because, you know, we bandy about this term, you know, we went from health disparities to health equity. Is it the same? Is it different? What is inequity? All that. So when I say the words health equity, and this definition actually is related to the Healthy People 2020 definition, to which I contributed, but it differs in an important respect, which I'll give you right now. So mine is a three-part definition. What is health equity? How do we get there? And then how is it related to health disparities? So I affirm health equity as assurance of the conditions for optimal health for all people. Healthy People 2020 starts out that health equity is attainment of the highest level of health for all people. And I agree that that's our goal. But I think that doesn't serve us well as a definition of health equity, because what if we hit that last Sunday? Are we done? And I'm very clear that health equity is not an outcome, it's actually a process. Which process? Assurance, which is actually one of the three core functions of public health identified by the Institute of Medicine, along with assessment and policy development. Assurance of what? Of the conditions for optimal health, which some people now describe as the social determinants of health. For whom? For all people. That's what makes it equity. How do we get there? Well, achieving health equity requires at least these three things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources not equally, but according to need. And how is health equity related to health disparities? Well, health disparities will be eliminated when health equity is achieved. Health disparities are the differences in outcomes. Health equity is all the stuff that comes before, the opportunity structures or exposure to risk and the like. So with that as a framing, I am now going to talk to you about different levels of health intervention, and to help all of us understand that, yes, there are different levels. We at some parts of our career might be working at one place or another. We need to understand the whole, the way all of these levels come together. And especially we need to understand that addressing racism and other systems of structured inequity is a core and legitimate component of being in the health space. So here we go. I call this my cliff analogy. Whoops, boom. Oh, boom, that was a delayed boom. But boom, somebody just fell off the cliff of good health. If that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on the care, right? But if we were concerned about other people who might come along that cliff face, so if we were concerned about population health, community health, public health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody in this assembly is going to say, I know, we've got to put a net halfway down. That way, even if people fall, we can catch them before they get crunched up at the bottom of the cliff. And that is an outstanding idea. Although the more you think about it, nets do have holes in them. So some people might fall through the cracks, but never mind that. We could make that a trampoline halfway down, no holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we do as a health intervention? Well, clearly we need to be thinking about a fence, right, at the edge of the cliff, to keep people from falling in the first place. But even that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, clearly we need to think about moving the population away from the edge of the cliff. So let me label the interventions that I have depicted so far, where the ambulance at the bottom of the cliff represents acute medical care, and what we on the public health side of the house describe as tertiary prevention, because we talk about three levels of prevention: primary, secondary, tertiary, where tertiary prevention is preventing complications from disease that's already manifest. So for example, preventing amputations from those people who have diabetes and the like. The net, or trampoline halfway down, these are our safety net programs, often in our social services, but can be co-housed with our clinical services. And they also include secondary prevention, which is early detection, screening programs, which clearly could be in a community setting or in our clinical settings. The fence at the edge of the cliff represents primary prevention, keeping bad things from happening in the first place. So in a clinical setting, that might be anticipatory guidance, it might be a vaccine. You know, in the more public space, it could even be a policy like a tobacco 21 policy to prevent young people from having easy access to tobacco products. And moving the population away from the edge of the cliff is about addressing the social determinants of health, which are those determinants of health and illness that are outside of the individual, beyond our individual genes and beyond our individual behaviors, where these social determinants of health are actually the context of our lives. They include individual context, so individual education, occupation, income, wealth. So addressing poverty is a very important way of addressing the social determinants of health. But these social determinants also include neighborhood context. So, you know, whether or not, you know, what's the quality of housing in a given neighborhood? What's the quality of the schools? Are there jobs in a neighborhood? And if there are not jobs there, is there even transportation to a job? What is the green space like? What is the availability of fresh fruits and vegetables and other healthy foods? Are you in a sacrifice zone right next to polluting industries or not? So many aspects of neighborhood conditions. So addressing adverse neighborhood conditions is another way of addressing social determinants of health. And I could go on giving examples of all of these. Let me just, for one health outcome, let me say, for example, for infant mortality as an outcome, the ambulance might be neonatal intensive care units. The net or trampoline halfway down the cliff might be prenatal care, which is actually screening pregnant women for, you know, early detection of adverse issues arising in the pregnancy. The fence might be maybe our women, infants, and children programs, WIC programs, to assure excellent maternal nutrition. And moving the population away from the edge of the cliff might be a living wage, right? You know, like a $15 an hour minimum wage, or maybe it's excellent educational opportunities so that young girls didn't feel like they had to have babies too soon as their main option in life. So you can see that we can have a community conversation based on this cliff analogy, right? We could go into a community and say, we recognize that you probably think we need some of all of this, but how should we be spending our limited health resources? How much in ambulances versus nets versus fences versus moving the population? We could even have conversations with our state legislators or with our Congress about that. But as useful as this diagram is, as I have presented it so far, it has a huge fatal flaw. And the huge fatal flaw is that it does not yet equip us to talk about how health disparities arise. So I want you to keep the cliff in the back of your mind for just a moment. We're going to shift gears to think about how health disparities arise on 3 levels. Come back to the cliff. So how do health disparities arise? Well, of course, they arise across many axes. So, you know, you have rural, urban health disparities, you have, you know, socioeconomic health disparities, we have racial, ethnic health disparities, which actually have such a long history in our nation, hundreds and hundreds of years, and occur across organ systems and you know, age groups and the like. And especially with regard to racial ethnic health disparities, we unfortunately also have lots of evidence about differences in the quality of care received within the healthcare system for people who are in the same healthcare system, say everybody in the VA system, or people who have the same insurance coverage, everybody covered by Medicare or Medicaid, differences based on race or ethnicity. So the Institute of Medicine in 2002 released its unequal treatment report, which pulled together what were then hundreds of studies documenting differences, for example, in how vigorously your chest pain might be investigated or treated depending on your race, or differences in how much pain medication you might get if you walked into an emergency department with a long bone fracture, depending on your ethnicity or your race. But that Institute of Medicine panel understood that differences in quality of care were not the end all and be all basis for racial ethnic health disparities, because they understood they were looking at people who are already in the healthcare system. And they frankly acknowledged that a second level at which health disparities arise are differences in access to the healthcare system in the first place. But I'm hoping that everybody in the sound of my voice recognizes that health is not created within the health sector. So there's a third very important level at which health disparities arise, which are differences in the conditions of our lives, differences in our life opportunities, exposures, resources, and risk, which are making some individuals and communities sicker than others in the first place. And if we were to try to contextualize these three levels at which health disparities arise, differences in quality of care, differences in access to care, and differences in underlying exposures and opportunities, why, we might draw it as a pyramid, or better yet, understand it as an iceberg where the huge hidden base are the differences in the conditions of our lives. And then very often, the same people who have been made sicker are frustrated because of limited access to the healthcare system. And then too often, even the lucky ones who get into the healthcare system are further injured because of differences in quality of care. So now, remembering these three levels at which health disparities arise, we are going to go back to our cliff. But now we're going to recognize that we're really not dealing with a flat two-dimensional cliff, but actually we're dealing with a three-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all. And maybe there's no net nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So let me label these observations about the three-dimensional cliff with how health disparities arise, where the differences in quality of care are represented when there's an ambulance there, but it has a flat tire, so it's slow or goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. And differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now that we recognize that we're actually dealing with a three-dimensional cliff, there is a whole new set of questions that arise. The first question, of course, being, how did the cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along that cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back here in a way and the greenies being pushed closer to the edge? And when we start asking and addressing those kinds of questions, we are doing something that differs from addressing the social determinants of health, which I described as moving the population away from the edge of the cliff. When we start considering systems of power that can differentially distribute resources and populations, we are now talking about the social determinants of equity or inequity, which include racism, sexism, heterosexism, economic systems like capitalism, and the like. So that with this cliff analogy, I have distilled three dimensions of health intervention. And going back to your junior high or high school geometry, one dimension is a line, two dimensions is a flat plane, three dimensions is space. Then it's along that line at the edge of the cliff that we can display all of our curative and preventive health services, the ambulance, net, and fence, all right there. That actually, if you say the word health, most places and to most people in this country, they will actually complete that thought for you and go immediately to thinking about health services or health care. Even all of our efforts to get the Affordable Care Act and efforts to shore that up and efforts to go beyond that and try to get to universal access to high quality healthcare, those are still edge of the cliff conversations. And I would say we need to get to universal access to high quality healthcare, not because that in and of itself will result in large and sustained improvements in health outcomes, but that is how a civilized society values all of its people equally. But even when we get there, we can overwhelm any system if there's a lot of population pressure against it. So we must go beyond our health services to really moving into that second dimension, which I can display in a flat plane, addressing the social determinants of health, including poverty, adverse neighborhood conditions, and the like, if we want to have large and sustained improvements in health outcomes. But the trick there is that if we are about addressing the social determinants of health, moving the population away from the edge of the cliff, without recognizing that we're really dealing with a three-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must acknowledge and address the three-dimensionality of the cliff. We need to address these social determinants of equity or inequity, including racism, sexism, heterosexism, and the like, if we want to achieve social justice and eliminate health disparities. And this is the point at which I would stop talking and engage your questions. And I often actually include other questions that people have asked me in the time, but also being cognizant of our limited time together. I just want to say, first of all, that I've said the word racism about 2 or 3 times, and I hope nobody fell off your chair. So we're going to now segue into a specific focus on racism as one of those social determinants of equity or inequity that's very important. It's foundational in our nation's history. Many people are in denial of its continued existence and profoundly negative impacts on the health and well-being of the nation. So that is where we're going to situate our work. But I also want to say that I recognize that I'm talking to many of you who are about trying to be the best ambulance drivers you can be, or to train the best ambulance drivers. You know, we're at the, you know, I am a family physician, so we operate at that, you know, that acute medical care level, as well as a little bit as a net, right? And sometimes, if we're lucky, as a fence, right? But we're right there along the edge of the cliff. What I need to say is, in our day jobs, we need to be doing the best that we can do for everybody. But in our day jobs, we need to recognize we are part of a bigger frame, right? That's about health. And that health is not just created within the ambulance. In fact, it's not created at all. It's maybe just sustained or held on to. But as we are doing our great job, I am so happy that you guys are training to be great ambulance drivers. Every time that I present for medical care, or when my parents were living, that I would take them even to an emergency department. So grateful. But in that role, you need to be wondering, is there a net above me, and how strong is that net? Is there a fence at the edge of the cliff? How strong is the fence? How close is the population to the edge? At what part of the cliff am I operating? And do I even do things in the same way at all parts of the cliff? So even in wherever you find your day job role is, you need to wonder and support as you can other elements of this. But I also say that as a person who is concerned about the whole, in your citizen role, and not in a narrow national citizen role, but as a global citizen role, I highly encourage all of us to be first concerned about the three-dimensionality of the cliff and addressing the disproportionate, distribution of resources and populations along this three-dimensional cliff. I've gone on too long for that. What I want to say is that because I believe this, actually 4 years ago, when I was the president of the American Public Health Association, I launched our association, and as many other associations and communities and schools as would join us, on a national campaign against racism with 3 tasks. The first of which is to name racism. The second, to then ask, how is racism operating here? To identify levers for intervention. And the third being to organize and strategize to act. So the rest of my time with you today is going to be to equip you with those tasks. I just need to mention that out of that national campaign against racism in 2016, in 2018, the Wisconsin Public Health Association passed a declaration that racism was a public health crisis. In May of 2019, the Milwaukee County Milwaukee County Board of Commissioners adopted that Wisconsin Public Health Association declaration. And there are now 131 jurisdictions, city councils, county boards of commissioners, in 5 instances, 5 states at the state level that have at least one jurisdiction. There are 26 states, 131 jurisdictions making these declarations that racism is a public health crisis. This is very important. We'll have to see what does it mean in terms of moving to action. But even when they are making that declaration, there are 4 key messages that we all need to communicate when we're naming racism. The first is that racism exists, because there are still many people, I would say perhaps the majority of people in this country still, who are in staunch denial that racism exists. So that's the first key message. The second is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth is that, yes, we can act. We can act to dismantle racism. So I am going to give you some tools right now for all of those things. The first allegory I'm going to share, and I say allegory because these are teaching stories that are actually based on something that happened in my own real life, right? So I'm going to tell you a story about something that happened to me. I called this story Dual Reality, a Restaurant Saga. And I will already tell you the moral of this story is that racism exists. That's the first key message that we all need to be able to convey. It's based on when I was a first-year medical student. So just come with me. Let me tell you this story. Here I am, first-year medical student, very diligent, very studious and hardworking. So I wake up on a Saturday morning and what do? I hit the books and I hit them hard. And I'm studying all the way through mid-afternoon when some friends come over. And when my friends came over, did they distract me? Oh no, we all got studying together long and hard, and now it's getting late and we're getting hungry and I have no food in the apartment, which was quite typical of me. So my friends understood and they were like, okay, never mind, Camara, but we're hungry. We need to go into town. Let's go into town and find something to eat. So we do. We go into town and we find a restaurant and we walk in and we sit down and the menus are presented and we order our food. And the food is served. And here we are eating. So you're like, Dr. Jones, that's not a very illuminating story about racism. Well, no, not yet. But as I sat there eating with my friends, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now maybe I've intrigued you. And you're like, Dr. Jones, so what did the sign say? Oh, okay. So what did the sign say? The sign said open. So now maybe I've lost some of you. So let me recap. Here we are sitting in a restaurant eating. I look across the room. I see a sign that says open, thinking no more about it. I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that indeed the restaurant was now closed due to the hour, but firmly closed. And that other hungry people just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food and eat. And that's when I recognized that racism structures open, close signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it's difficult for any of us to recognize a system of inequity that privileges us. So for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context. But those on the outside are very well aware that there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But when you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, but here we are all health professionals, so I think we do. But so if you care about those on the other side of the sign, well, you could even talk to the restaurant owner who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door? Let them come in. You'll make more money. And oh, the conversations we could have. Or maybe what you'll do is pass food through the window. Or maybe you'll try to tear down the sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of that sign. So I tell this story when I have 4 or 5 minutes to talk to a group of people to convey the fact that yes, racism is structuring two-sided or multi-sided signs in our society. It's creating a dual or multifaceted reality. And I actually started a 3-hour conversation once by sharing this story with a group of people in Flint, Michigan, and then asking the question, how could people who are born inside the restaurant know something about the two-sided nature of the sign? And it was a 3-hour conversation because there are many, many ways to know. I won't do that now because we can't have the conversation, but maybe you can remember this story and share it with some of your friends and colleagues and family members, and maybe you can have that same conversation. What I do want to say is I am so heartened that in the past 6 months or so, more people, at least since April, more people who were born inside the restaurant and might have before said something like, what are those people saying outside? Black Lives Matter? Don't they know all lives matter? Are now understanding that, yes, it's appropriate to affirm that Black Lives Matter. There are more people born inside the restaurant who got a little flicker of the sense that there is a two-sided nature to this sign and are now putting together the words systemic racism or structural racism. I am so heartened by that, I must say, having done this work for decades. But I have a warning for all of us. The warning is that if we just say a thing, then in 6 months' time, because racism denial in this country is so staunch and so seductive, in 6 months' time, we might forget why we said that thing and fall back into what I describe as the somnolence of racism denial. So we have to go beyond saying a thing to acting, to doing a thing. And of course, racism is not just the sign, it's the door, it's the lock. So what we need to do is try to tear down the sign. We need to dismantle the lock. We need to take the door off the hinges. If we start acting, we will not forget why we are acting. Now, I want to just quickly give you my definition of racism, because now I have said it a long time, and yet here we are, and I haven't defined it yet. So when I say the word racism, I'm clear that I'm talking about a system. I am never trying to divide them into who's racist and who's not, or look at somebody and say, well, exactly how racist are you? Racism is not an individual character flaw. Racism is not a personal moral failing. Racism is not even a psychiatric illness, although it can manifest in all of those ways. But racism in its essence is a system of power, and a system of doing what? It's a system of doing two things: structuring opportunity and assigning value. And on what basis is the opportunity structured, and on what basis is the value assigned? It's based on the social interpretation of how one looks, which is what we call race in this country. And I certainly don't have time to give you my 1-hour lecture on what is race. Just to understand that the social assignment of people in this country, the on the street kind of characterization of so-called race without even asking, excuse me, how do you self-identify? Or excuse me, where were you born? Where were your parents born? Or even, excuse me, may I have a little aliquot of your blood? Because I have a genetic hypothesis. That on the street socially assigned race is the substrate on which racism operates historically and day to day. And this system, racism, has several impacts. The first of which is, when we finally do talk about racism in this country, we mostly recognize that racism is unfairly disadvantaging some individuals and communities. But it shouldn't take us long to realize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people, especially some people who are living as white, uncomfortable. And when I share these thoughts, in other instances, I used to almost apologize at this point for that discomfort. I would say, well, if you feel a little uncomfortable, just shake it off. Stay with me. I'm going to tell you more stories. I don't say that anymore. What I say now is, if you feel uncomfortable, you need to lean in. Because I have come to recognize that for all of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism, which is that it saps the strength of the whole society through the waste of human resources. So it's not just that Black lives matter, for example, it's that Black lives are precious. Because Black lives are genius, and Black lives are leadership, and Black lives are creativity and generosity and love. And when we constrain Black lives and Indigenous lives and Hispanic Latinx lives and Asian lives and Native Hawaiian, other Pacific Islander lives, and all of these racialized lives, when we constrain those lives slowly by not vigorously investing in the full, excellent public education of all of our schools, because the blinders that some decision makers wear makes them believe that there's no genius in the barrios or the ghettos or on the reservations, we can get along very well, thank you, without those kids. When of course there's genius in all of our communities. And if we were to only vigorously invest in that genius, we could be doing so much better as a nation or even as a world. Or when we constrain those Black and Indigenous and other people of color lives slowly by being complacent with what I describe as the wholesale warehousing disproportionately of so many Black and brown men in our prison systems, or the separation of families, children from their parents at our southern border, or so many of other things, as if that didn't separate us from human potential. Or when we snuff out these lives in an instant in a barrage of police bullets or with a police officer's knee, it is not just the humanity and the genius that's been lost. This represents a sapping of the strength of the whole society through the waste of human resources. I think of the 3 impacts of racism that I have outlined today. This is the one that we need to elevate in our media stories, in our data collection, if you're a researcher, in conversations around our dinner table, so that we have more people understanding that and engaging with dismantling racism to put in its place a system in which all people can know and develop to their full potentials. I actually, going beyond that kind of global definition of racism, also have tried to understand, well, how could racism turn into health outcomes? How could racism turn into differences in asthma prevalence between populations, or differences in the numbers of our babies dying before their first birthday, the infant mortality rate, or differences in numbers of birthing families where the mother, the pregnant woman dies within a year of pregnancy, the maternal mortality differences between populations, or differences in obesity prevalence, or diabetes prevalence, or heart disease prevalence, or renal disease, kidney disease prevalence, and all of these other pre-existing conditions, which are making it more likely if somebody is infected with the SARS-CoV-2 virus that they will die from COVID-19. How is racism turning into these health outcomes? And to understand that, I describe 3 levels of racism: institutionalized or structural. I published this paper that I'm presenting to you right now 20 years ago. So I call it institutionalized, and it's the same thing as structural. Personally mediated, which some people call interpersonal, but because I understand that racism is a system, this is the system mediated through people. And even though personally mediated can be a tongue twister, that's a more accurate description of what that level is. And then internalized. So I'm going to very briefly define these 3 levels of racism for you, illustrate them then with a Gardener's Tale allegory, and then speed on through the rest of my slides. So institutionalized racism is the system, if you will. It's the constellation of structures, policies, practices, norms, and values, which taken together result in differential access to the goods, services, and opportunities of society by race. So this is the kind of racism that does not require an identifiable perpetrator because it's been institutionalized in our laws and customs and background norms. This kind of racism shows up as inherited disadvantage, or as reciprocal inherited advantage. And we see it both in terms of material conditions as well as in terms of access to power. So examples include differential access by race to excellent, quality housing or excellent educational opportunities, or equal employment opportunities, or even the same level of income at the same level of employment. So clearly those things impact health. Differential access to medical facilities, which is not even just physical access, it includes financial access and linguistic access. Differential access to a clean environment, and the very well documented disproportionate placement of toxic dump sites or bus transfer stations in communities of color. And with regard to power, differential access to power as information, which could be health information, or even health information in a language that you can understand, right? Or it could be information about our own histories. Differential access to power is resources, not just capital resources, but social networking resources, and differential access to power as voice in media, government, and the like. Now, I have been challenged in the past showing this slide where somebody has asked me, excuse me, Dr. Jones, would you take a careful look at that top set of examples you have there where you talk about housing, education, employment, income? Isn't that what we call social class? So why do you have that on a slide about racism? Are you talking about racism? Or are you really, really talking about social class? This is such an important question that I'm going to stay on this slide just a little bit to answer it. And the answer to that question starts with the observation that it doesn't just so happen that people of color in this country are overrepresented in poverty while white people in this country are overrepresented in wealth. It's not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. So for American Indians, the initial historical injustice was the taking of the land, and then the near genocide, and then moving the survivors to reserved lands. And then in some instances, something good was found under one reservation. Oops, you got to pick the people up and move them somewhere else. And I usually talk about the centuries and centuries of families that lived in Mexico never crossed the border, but the border crossed them, right? And the harassment and the targeting there, or Chinese laborers brought to this country to build our railroads, unable by law to marry and unable by law to bring their families, about the internment of Japanese Americans during World War II without the internment of German Americans or Italian Americans, and for people of African descent, where the initial historical injustice was the kidnapping of West African people and our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors and their progeny for generations and generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then people hear me talking like that and they're like, oh, Dr. Jones, there you go talking about slavery. Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865. And we're in 2020, which makes that 155 years ago. So all else being equal, Dr. Jones, don't you think the impacts of slavery would have washed out by now? Well, the key phrase, of course, the answer, of course, is in their question, all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are what I describe as present day contemporary structural factors that are perpetuating that and all of these other initial historical injustices. And these contemporary structural factors are part and parcel of structural racism. So when you ask me, am I talking about institutionalized or structural racism, or am I really talking about social class? My answer is that institutionalized racism explains why we even see an association between social class and race in this country. It doesn't just so happen. This is an important aha. I also need to very quickly say that because I'm deeply concerned also about the well-being of all poor people, including poor white people, as well as poor racialized people. This is not an either or proposition, anti-poverty versus anti-racism. In fact, we need very vigorous anti-poverty interventions. Indeed, we do. And if you were to give me a magic wand today, indeed, I would use it to eliminate poverty. And if I could do a double ding and eliminate income inequality and equalize income across all, I would even go that far. Yes, I would. But if I did that without addressing the background structures, policies, practices, norms, and values of structural racism, then even if I equalized income today, in one generation, we would start to see a stratification by race in terms of income. This is not an either or proposition. We need anti-poverty and anti-racism strategies together. Now, structural racism, I also need to say before I leave this, can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission, and very often shows up as inaction in the face of need. I am getting so low on time that I'm going to quickly define each of my other levels so that I can tell my story, but I'm not going to go as deeply into the examples. So personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. That's what most people think about when they hear the word racism. Somebody did something to somebody. It includes the different idea, the prejudice, and the different action, discrimination, and it can show up as police brutality, physician disrespect. I do need to stay there. For people who are becoming osteopathic physicians, and all of those of you who are training all of these young healers, physician disrespect can be as subtle as a physician not giving a patient the full range of treatment options because the physician figures that patient wouldn't understand or couldn't afford or wouldn't comply or whatever they assume about the patient. Or it could be quite blatant, like sterilization abuse, which has had many iterations in our nation's history. We must be aware of ourselves at all times, right? And of the systems in which we operate. Shopkeeper vigilance, waiter indifference, teacher devaluation. Personally mediated racism, like institutionalized or structural, can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. But even more important is that it can be unintentional as well as intentional. You do not have to have intended to do something racist to have had a racist impact. The third level of racism, internalized racism, I'm defining here from the point of view of members of stigmatized races as acceptance by members of stigmatized races of negative messages about our own abilities and intrinsic worth. It shows up as self-devaluation, feeling maybe I'm really not as good as, maybe I shouldn't try to graduate from high school or apply to that college or try to get that job or live in that neighborhood. It shows up as the white man's ice is colder syndrome, where that phraseology came to me from my parents' generation, and what it meant for many people of color back then, it still means for many of us today. So here I am Black, say I'm Black and I need a lawyer. I might actually seek out a white lawyer over a Black lawyer. Or if my lemonade were cold, I might go way down the street to get the white man's ice over the Black man's ice, deeply believing that the white man's ice is colder, deeply internalizing that the myth of white superiority. It shows up as resignation, helplessness, hopelessness, which turns into a lot of self-destructive health behaviors, turns into not registering to vote sometimes, turns into not voting even if we are registered. And there have been such strong efforts to disenfranchise so much of our citizenry that I hope that you are resisting those efforts. And I hope that all of you, I can't even guess who you might vote for, but we all need to be in this. We all need to be voting and getting other people to vote. This is our right in this democracy. But anyway, back to internalized racism, it's about accepting the limitations to our own full humanity of the box into which we've been placed. So that when we hear young high school students of color, where one of them's trying to be the valedictorian of the high school, and the friends are teasing her or him by saying, well, so-and-so is just trying to be white, we need to challenge that, because since when did white people claim exclusive access to excellence? They did not. So now, even though I just have 4 minutes left before I was going to try to close, I am going to stop sharing to tell you my story, and then I'm going to start sharing again. I use my hands a lot for this story, so that's why I'm going to stop sharing. But then I'm going to start sharing again, and then very quickly go through the rest of my slides. So this story, Levels of Racism: A Gardener's Tale, was sparked by the real life experience I had with my husband. Let me tell you the thing very quickly that happened to me, and then we'll make it a story about racism. My husband and I married about a year, moved down to Baltimore. I'm going to finish my PhD at Hopkins. We buy our first freestanding house, cute little house, big wraparound porch, flower boxes dotted all on the porch. We bought it in October, not the time to plant. But when spring came, my husband, who loves to garden, ran out with our marigold seeds, going to decorate our cute little house. And then he came right back in because he said, some of these boxes have dirt in them, but some of the boxes are empty. So he goes down to the gardening store, hauls back big old bags of potting soil. We fill up the empty boxes. We sprinkle equal numbers of our marigold seeds in all of the boxes. We water them all equally. And because by that time I was exhausted and I'm not the gardener, I decided I was just going to sit back and be delighted. 3 weeks later, I'm walking out of my front door. I finally pay attention to these flower boxes on my porch. And what I saw made me literally stop in my tracks, because what I saw made me think that we had planted completely different species in some boxes versus others, because some of the boxes were full of plants and they were tall, vigorous looking plants. And some of the boxes just had a few plants in them and they were kind of scrawny and scraggly looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil, so that every single seed planted in the rich, fertile soil had sprouted. And the strong seed had grown very tall and vigorous, but even the weak seed had made it halfway up. But that old soil that we had found there turned out to be poor, rocky soil. So the weak seed planted in the poor, rocky soil just died. But even the strong seed in the poor, rocky soil had to struggle to make it to a middling height. And maybe some of you are nodding, because maybe some of you are gardeners and you've composted half of your garden. So maybe you've seen this image with your own real eyes. And the image, of course, is about the importance of the soil, the importance of the environment. But now I'm going to take that image and I'm making it a story about racism by introducing a gardener. So now we have a gardener who has 2 flower boxes, one which she knows to have rich, fertile soil and one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms and some of the seed is going to produce red blossoms. And the gardener prefers red over pink. So what does she do? She takes the red seed, puts it in the rich, fertile soil, pink seed in the poor, rocky soil. 3 weeks later, she sees in her flower boxes what I saw in mine. In that rich, fertile soil, all the red seed sprouts, strong red seed, tall and vigorous, even weak red seed makes it halfway up. In the poor, rocky soil, the weak pink seed dies. Here comes a strong pink seed struggling to make it to a middling height. And then in those flower boxes, those flowers go to seed. And the next year, the same thing happens. And then those flowers go to seed. And year after year after year after year, same thing happens till finally about 10 years later, the gardener is looking at her flower boxes and she says, I was right to prefer red over pink. So we interrupt the story there to say the first part of the story is how structural or institutionalized racism works, where you had the initial historical injustice of the separation of the seed into the two types of soil, contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, lack of action in the face of need, perpetuation of the inequity. But where is personally mediated racism in the garden? Well, the gardener is looking at her flower boxes and she says, oh, those red flowers are so beautiful. And then she looks at the pink flowers and she says, oh, those pink flowers sure are scrawny and scraggly. So she plucks off the pink blossoms before they can even go to seed. Or she might notice that a pink seed has blown into the rich, fertile soil. So she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in the garden? Well, the red flowers are just living their lives, enjoying being red, many of them not acknowledging or perhaps not even understanding that they're benefiting from enriched soil. Pink flowers are looking over at red, thinking red is mighty fine and wishing with all their hearts that they too could be red. And here come the bees, minding their own business, collecting nectar, but pollinating at the same time. So here comes a bee into one of the pink flowers and to another pink flower and to this pink flower. And this flower's like, get away from me, bee. Don't bring me any of that pink pollen. I prefer the red, because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink. And that is an important intervention. But if that's all we do, it's not going to change the situation in which the pink flowers find themselves. So you say, okay, well, let's address the personally mediated racism. Let's have a conversation with the gardener, or better yet, let's have a workplace multicultural workshop for the gardener. So we do all that. And in the workshop, we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, maybe she won't. But even if she does, it's not going to change the situation in which the pink flowers really find themselves. If we want to set things right in the garden, we must address the structural racism, which means we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too. Although it does make it easier for that same gardener to keep segregating resources going forward. But if you decide to keep separate boxes, what it means is you need to enrich that poor rocky soil until it is as rich as the rich fertile soil. And when you do, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious, so that in that intervention on the structural racism, we will have also addressed the internalized racism, because pink will no longer be looking over at red, thinking that red is better or wanting to be red. And in the intervention on the structural, you may also address the personally mediated racism. Now, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful will be less likely to have this kind of attitude. So the story has been to illustrate these three levels of racism and strongly suggest that if we want to set things right in the garden, we must at least address the structural racism. Good to address all the levels at the same time, but at least address the structural, and when we do, the other levels may take care of themselves. But before we leave this story, there's one more question, very important question, which is, who is the gardener? After all, the gardener is the one that I gave the power to decide, the power to act, and control of resources, which are actually the elements of self-determination. So who is the gardener? Well, government's a huge part of the gardener, but not the only part. Media, foundations, corporations, communities, to the extent they have self-determination. But whoever is the gardener, it is dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink. And it's also dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. And so our challenge now is, what do we do about the gardener? Do we make the gardener striped or polka dotted or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Again, lots of questions can come out of this, and I encourage you to remember this story and share it and discuss it. I just want to share two questions that have come up before, and then I'm going to race through the end of my presentation because I really did prepare it for you and I had some stuff I needed to say. So the two questions though is, the first question that I was once asked that I must share with you: why should the red flowers share their soil? When I heard the question, I loved the question because it showed me the power of the story to start conversations about racism that might be otherwise difficult if we were talking about racism between you and me. My answer to the question, why should the red flowers share their soil, is that actually that soil doesn't belong to the red flowers. It belongs to the whole garden. But the second question is, what if that's not the original gardener that we're looking at right now? What if that's the gardener's great-great-great-great-grandchild? Because here we are. And the great-great-great-great-grandchild has always seen the flowers looking like that, may not even think there's a problem to be solved. So in 3 quick steps, First, we must make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. Put it at the top of the agenda. Second, in order to solve it, now that it's on the agenda, we must make those flower boxes transparent. We must be talking about the differences in the quality of the soil so that we can address the differences in the quality of the soil. And third, as we make those flower boxes transparent, we also need to be clear to communicate that the pink seed did not just go launch themselves into that poor rocky soil. So we must talk about history, and we must talk about how the gardener's initial preference for red over pink set up the whole situation. And some people might call that cultural racism. In our context in the country right now, it's white supremacist ideology. We must address that, because if we do not, even if we were to compel that red gardener to enrich the poor rocky soil today until it was as rich as the rich fertile soil, if she continues to prefer red over pink, she will continue to privilege red over pink. So when I described racism and defined it as a system that does two things, structures opportunity and assigns value, we need to address both of those if we're going to set things right. The question, how is racism operating here, gets us to identifying levers for intervention, because the mechanisms of institutionalized racism are identifiable and addressable, and they are in our structures, policies, practices, norms, and values, which are actually different elements of decision-making, where structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. So if we take this question with us everywhere, how is racism operating here in my child's school, at my workplace, in this community, with regard to COVID-19 and the disproportionate impact of COVID-19 on communities of color. I knew I wasn't going to have enough time to share all of those examples, but I do say that that is the meat, that is the tool that will enable you to identify in your location areas, levers for intervention. There are 7 factors that I used to describe as 7 societal or cultural barriers to achieving health equity. I now recognize them to be the 7 values targets for anti-racism action. We have structural targets and values targets. Very quickly, we are so narrowly focused on the individual that it makes systems and structures either invisible or seemingly irrelevant. We are ahistorical. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. We endorse the myth of meritocracy, the story that goes something like this: if you work hard, you will make it. Now, I give you that most people who have made it have worked hard, but there are many other people working just as hard or harder who will never make it because of an uneven playing field that has been structured and is being perpetuated by racism, sexism, heterosexism, all of these other systems of structured inequity. And when we deny those systems, we are endorsing the myth of meritocracy, and we are blaming those who haven't made it for being lazy or stupid. And there are many ways to deny racism. One is to say, I don't think racism exists. And we've heard even, very government officials say that. But another way to deny racism is to never say the whole word, racism. You could be talking about diversity, equity, inclusion, belonging, cultural competence, structural competence, disparities, disproportionalities, race. You could be talking about all that stuff. But if you never say the full word racism in our national context of widespread racism denial, then you're complicit with that denial. The fourth, the myth of a zero-sum game, that if you gain, I lose, which sets us up in competition. And it's like I'm sitting at a potluck dinner, I see you coming, and I don't want you to come over here because I think you're going to eat up all the food. I don't even recognize that you're bringing all kinds of cakes and pies and roast and fruits and salads and all kinds of good things with you because I don't even value you. The fifth is our limited future orientation. The parts of the future that each of us can touch today are the children and the planet. In this country, we have a disregard for the children and a usurious relationship with the planet. The sixth is this myth of American exceptionalism, that we're so special, so different, so ordained by God, that there's nothing that we could learn from other nations. And if we would only learn from other nations' successful approaches to containing this COVID-19 pandemic. And the seventh is actually the foundational one, white supremacist ideology, which I do not use as a lightning rod term. It is the simple description of a false idea of a hierarchy of human valuation by race, with white people at the top as the ideal of the norm, but it gives people who are living as white a sense of entitlement. It results in the dehumanization of people of color and fear at the browning of America that's underlying a lot of our politics these days. So what can we do today? I had said, our conversation today was going to be anti-racism as a legitimate health intervention. And I gave you a definition, a cliff analogy. I talked about the National Campaign Against Racism, tools for naming racism. I gave you 2 allegories and some definitions. Tools for moving to action. I've gotten to everything except what can we do today? What can we do today? We need to actively shine the bright light of inquiry, look for evidence of two-sided signs. Is there something differential going on by race, by language, by gender, by ethnicity, by immigration status, by urban rural status, by religion, right? We need to burst through our bubbles to experience our common humanity. Each of us is in a bubble of experience. We most often do not realize that just across town, there are other people who are just as kind, just as funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to burst through our bubbles of, our experience to experience our common humanity in different circumstances so that we can start developing common cause. We need to be interested in the stories of others and then believe the stories of others without requiring cell phone video documentation. And then we need to join in the stories of others. And I'm heartened that more of us are doing that. We need to develop a sensitivity to the absence of. Who is not at the table? What is not on the agenda? What policies are not in place that if put in place could be quite productive? And we need to reveal inaction in the face of need, because that is how structural racism most often manifests these days. But all the power is not just on the power on the, at the fingertips of those inside the restaurant. Those of us on the outside need to know our power. We need to recognize that action is power, and especially that collective action is power. So I've been so delighted to share these thoughts. I know that there's no time for questions, and I give it over now to Dr. Hopper for the raffle.
Thank you so much, Dr. Jones. You've really given us so much to think about today, starting with that really nice cliff analogy. And then you called us all to action. Take down the sign, disable the lock, tear down the door. And I hope that our audience today will consider doing that so all of the flowers in the garden can bloom. You're right, it's a little touching, it's a little moving, it's almost a little emotional for me to hear that message today. In closing though, I'd like to first thank Dean Henley for his vision, for this opportunity, for the research committee to make this come to fruition, to all our participants today willing to hear this message. And to you, Dr. Jones, thank you so much for accepting this invitation. I know how busy you are at this time. To close today, though, I would like to thank Brandon Cooper and the Office of Student Activities for making the gift basket possible. And the student winner today is actually Benjamin Baum. So that can be picked up right here at the College of Medicine. Again, thank you all for Zooming in with us today. Have a delightful afternoon. For those of you who are in the College of Medicine, let's give Dr. Jones about 5 minutes, and then each of you should be logging in with your individual links that were provided on your registration, and you do have an individual password. So look for your email with your link and your password, and we'll see you in about 5 minutes. Thank you, Dr. Jones.
Thank you so much.
Virtual applause from the audience, I'm quite certain.
Thank you very much.
Dr. Jones?
Hi, you're muted. And I'm muted too.
Go ahead and take a minute and stretch your legs.
Oh wait, we're still live.
And then you have that